This is the Shelbourne Knee Center podcast. This is Dr. Benner, and I'm here with my co-host, Scott Bauman. And tonight, we're going to be talking about an interesting topic as it relates to total knee arthroplasty. We're going to be talking about the impact of diagnosed chronic sleep disorders on outcomes following total knee arthroplasty. This is a paper that we did with one of our resident colleagues from Wright State University, and this was presented as a poster at the APTA Combined Sections Meeting just recently in Boston, Massachusetts at that meeting. So looking forward to reviewing this topic tonight.
Before we jump into this total knee topic, if you haven't listened to the last episode, I would recommend going back, especially for those physical therapists out there that are treating patients after surgery or non-operatively. We had on Joel Novak from Community Health Network. He talked about blood flow restriction, and we really had a great conversation about how he utilizes that in different populations with knee conditions, again, whether that be ACL reconstructions, total knees, non-op OA. So again, if you haven't listened to last week's episode, go back, listen to that, and it's a great conversation with Joel on blood flow restriction.
You can get our podcast anywhere you get podcasts, through Google Podcasts or Apple Podcasts. You can also find us on social media at Instagram and Twitter at the SKC Podcast. You can email us at the SKC Podcast at gmail.com, or you can find us on Facebook and YouTube and go to the Shelbourne Knee Center podcast pages. Tonight, we do have another guest. This is a Wright State resident named Dr. Fehmi Berkay. He is a resident that we got to know through a former colleague of Dr. Shelbourne's, one of his former fellows, actually, that is an attending with Wright State University and has gotten us connected with some of the resident physicians there. We've been able to work on some research projects. So, Fehmi, thank you for joining us, and looking forward to our conversation tonight.
Dr. Benner, hey, Scott. Thank you for having me. I look forward to talking about our paper.
So let's go back to when you first started thinking about this topic, Fehmi. What was it that really drew you to this topic, and how did we get this study off the ground?
Sure. So just to give a little background, I had a research year at my own program at Wright State. So during this year, you have some clinical duties, one of them being at the VA. We often take part in the joint reconstruction clinic. So we see a lot of post-op total knee and total hip patients. And it just caught my attention seeing, hundreds of patients that you'd see the same x-rays in the different patients and have very similar exam. And despite that, some of them would be unhappy with their results, and others would be completely happy and couldn't thank you enough. So I was just curious, why are some of these patients unhappy? And I got into reviewing a little bit of literature, and it was pretty consistent with what I was seeing as well. About 15 to 20% of total knee arthroplasty patients are dissatisfied after knee replacement, even though there's no objective abnormalities found on x-rays or exam, or no range of motion difficulties. So a lot of patients just are dissatisfied on patient-reported outcomes. So I wanted to see what possible reasons this could be. And one of the things that I ran into was that sleep disturbances and patients with sleep problems can have increased pain sensitivity. So I was just curious if this was a possible cause or association with patients being dissatisfied after total knee replacement. So that's how I got into this topic.
Yeah, and this is something that as we go to meetings, Scott and I just recently went to our academy meeting. So much in joint replacement and knee replacement in particular is trying to get at what are those factors that we could potentially change? What are things that we could potentially modify or maximize in order to make our patients' outcomes better, to try to get at why are those patients dissatisfied with their knee post-surgery? And it's interesting to think about the impact of other medical comorbidities. There are some obvious ones as it relates to diabetes and other risk factors for infection. Obesity, there's still a lot of studies talking about whether or not obesity has an impact on our outcomes. I think it's pretty clear that they do, but what kind of impact does that have on our ultimate outcomes? And there just hasn't been a lot of study about sleep disturbances. I think it's something that we've all experienced clinically, that our patients post-surgery after knee replacement often have sleep disturbances. But I've never really looked that far into what kind of impact sleep disturbances have on our patients pre-surgery, how that affects their kind of journey to getting to the operation to to begin with, and then post-surgery, how the improvement of their symptoms after their arthroplasty contributes to and hopefully improves their sleep function. So talk to us a little bit about the background that you found when you went and looked this up as kind of an introduction to this paper. What studies are out there pertaining to the topic, and what did you think that this study was going to potentially add to it?
Just like you mentioned, so obviously there's a lot of previous literature based on looking at patient comorbidities that you would obviously guess to be risk factors for patients doing poorly. So something like patients having diabetes, or patients with high ASA classification, just general patient population that would likely do bad after surgery or even during surgery. And then there's other more obvious factors like component positioning, post-operative, infection, post-operative alignment that would obviously have an effect on your outcomes. But then some of the psychosocial factors aren't as adequately addressed. So what I found in previous literature, there's a lot looking at psychosocial factors such as anxiety and depression. There's not really any studies looking at chronic sleep disorders. And there's some literature looking at perioperative sleep problems, I should say. So I found multiple studies that looked at patients that complained of sleep disturbances just before surgery, and they identified these patients looking at perioperative sleep questionnaires. But I thought that this may kind of skew data because you have anxiety around surgery. It's probably endpoint arthritic pain. So it's not going to be as influential as someone who has a sleep problem, probably 6 months or a year out. And what would be more adequate to address this is if, you identify patients with actual diagnosis of sleep problems like sleep apnea, insomnia, and such, and then look at their outcomes.
Yeah, I'm glad you mentioned that, Fehmi. When you talk about actual chronic sleep disorders, which is what we were looking at in this paper here, when you're doing your lit review, were there any common diagnoses that seem to be discussed or written about more so than others? I know you mentioned insomnia and things like that, but were there pretty common ones that seem to hit the literature more so than others, or was it just broad sleep disturbances or sleep disorders generally?
So yeah, that was the problem in previous literature, honestly, is that there wasn't really any focus on chronic sleep disorders. It was more of perioperative, 2-week or 1-week sleep questionnaires, and the authors identified patients that they labeled as having a sleep disturbance just based on this perioperative questionnaire. So I didn't really find anything where they looked at chronic sleep problems and its effects after total knee replacement.
Yeah, and I think that's where we're really trying to bridge the gap with this paper was not just does surgery disrupt people's sleep? Do people struggle with sleep post-operatively? I think that's pretty well studied. And when you brought this study to us from the beginning, I had to stop and think for a little bit as what I thought the results were going to be and how I would even wrap my head around this and potentially come up with a hypothesis. Do I think people with sleep disturbances would do worse? Probably, but could they possibly do better? I guess so. And it was tough to really kind of wrap our heads around that and come up with some hypotheses. So what were your specific thoughts on that, Fehmi, as we got into this study, and how did that end up? How did that end up after looking at all those studies, figuring out this is a potential hole in the literature, this is how we could potentially address it, and this is what we hypothesize that we're going to find?
Mm-hmm. So, yeah, I mean, what I found is that majority of previous literature discussed patients with sleep disorders being more pain sensitive, and the wording they often would use is pain catastrophization. So
one of my favorite terms in all of medicine, pain catastrophization. Love that one.
I know it's difficult to say. I have to really focus on it. But yeah, so regardless of whether we're talking about knee arthritis or any other chronic pain syndrome, previous literature points to the fact that patients that have sleep issues have increased pain sensitivity and are more likely to complain of chronic pain compared to patients that don't have chronic sleep disorders. So based on that, I figured that patients that we identified as having chronic sleep disorders would do poorly after total knee replacement compared to patients that don't have those sleep disorders preoperatively. Again, relating back to the issue of pain sensitivity. So that's what our hypothesis was.
Yeah, and I kind of eventually came to that as well. I'm like, these patients, they have to do worse, I would think. Especially, I mean, just in general, if people don't sleep well, a lot of times that's what pushes them over to surgery in the first place. A lot of patients who say there were a lot of things that I could put up with. I could take the pain throughout my day. I could take the activity modification. But when it got to the point I couldn't sleep anymore, Dunzo, they were ready to go on with surgery after that. But I really thought we're talking about people with real sleep disorders here: chronic insomnia, narcolepsy, sleep apnea. Some real diagnosed chronic sleep issues. And I really thought this was going to end up with our patients doing worse.
Yeah, from a physical therapy perspective, I mean, when you and I talked about this early on, we talked about anecdotal evidence and what we see with these patients. And Dr. Benner, you tell these patients this postoperatively as well. And, we're seeing these patients almost weekly for the first 4 or 6 weeks or so. And the number one complaint usually at that, definitely the 4-week, and then even still at the 2-month visit is, I just can't sleep. So my thought as seeing these patients postoperatively is, obviously, they're more pain sensitive if you have a chronic sleep disorder. So my thought from a PT perspective, looking at this from a postoperative standpoint, is really everybody complains about poor sleep quality. Would the chronic sleep disorder make that more sensitive to that? So yeah, from a post-op PT perspective, I would have agreed with that hypothesis as well. I would have thought that they would be worse after surgery. Now, getting into the actual project here, Fehmi, can you describe the methods you used for this study?
Yeah, sure. So this was a retrospective review, and we looked at patients that underwent primary total knees only for knee osteoarthritis. And it was, we did it using a prospectively collected database of patients at a single institution, and it was between the years of 2018 and 2022. I'll talk about our inclusion criteria and exclusion criteria, which I do feel like is important and can affect outcomes. So the inclusion criteria were patients that did not have revision surgeries, bilateral procedures, stage procedures within 12 months of each other, or postoperative complications that would require a return to the operating room. And so these are kind of shared inclusion-exclusion criteria. And I mean, you can guess by the list of those factors how they would affect patients having poor outcomes postoperatively. Some of the other variables that we looked at were age, gender, BMI, ASA class, and we looked at those just to ensure that some of those were not confounders in our study. And then we identified chronic sleep disorders by using CPT codes for sleep apnea, insomnia, narcolepsy, restless leg syndrome, and I think that's it. I think that was pretty extensive list of chronic sleep disorders. And we administered KOOS surveys preoperatively, and then at 1, 2, 6 months and 12 months postoperatively. The primary outcomes that we were looking at is looking at the different subdomains of KOOS, so pain, sport, activities of daily living, as well as the total KOOS score. And then we compared those two groups, looking at patients with documented sleep disorders based on CPT codes, and those without sleep disorders as well.
So with those outcomes you were looking at, what were the results that you found?
Mm-hmm. So overall, we had 172 patients total in the study. There was 43 patients in the group with a diagnosis of a chronic sleep disorder based on CPT coding, and then 129 patients in the other cohort. So as a summary of the results, it's interesting. Most of the results were actually identical, regardless of the KOOS subtype that we were looking at. And it's that postoperatively after total knee arthroplasty, patients in both the sleep disorder and non-sleep disorder cohorts made significant improvements over time at the 1, 2, 6, and 12-month marks. And for a majority of the comparisons at each specific time interval, there were no significant differences between the groups. But when you looked at the group time interaction, meaning is there a difference between the groups that is significant as it relates to change over time overall? And looking at that, the patients with sleep disorders actually seem to do better with respect to over time, over the entire 12 months.
Let's back up just a second, Fehmi, and talk about the preoperative results that we found from these groups. Obviously, one of the differences that we were wondering was pre-surgery. Are these patients about the same, or is there something about their sleep disorder that even makes them worse in the preoperative phase? And then how does that play into not only the outcome that they have, but the difference in their pre to post-op outcomes?
Yeah, so as far as preoperative results between sleep disorder and non-sleep disorder patients, preoperatively, patients in the sleep disorder group tended to do worse on all KOOS subdomains, but there wasn't significant differences in each KOOS subdomain. But there was a general trend towards patients with sleep disorders doing worse preoperatively.
Yeah, both of those groups had KOOS scores in the 40s, but the means differed by about 4 points, which is below the minimal clinically important difference and was not statistically significant. But I think we can all agree that a 4-point difference in the preoperative phase does seem to be selecting out a group of patients that are, at least in some degree, a little bit worse pre-surgery just because they have a sleep disorder. Along that same vein, from that portion, once we've identified that they were a little bit worse in the preoperative phase, now let's move on to the postoperative phase. What did we find about these patients once they got done with surgery?
So postoperatively, so we had two different ways of comparing these groups, actually. We looked at both comparing the groups at each individual time point, that being 1 month, 2 months, 6 months, 12 months postoperatively, and then also looking at the group time interaction over the 12-month period overall. And interestingly, in all the KOOS subdomains, if you look at each specific time frame, both groups made significant improvements after total knee replacement. So because of both groups making significant improvements, if you look at each specific point, there tended to be not any significant differences between groups. But if you look at the 12-month period overall, patients with sleep disorders actually tended to do better with significant differences.
Yeah, at the 1 year mark, the sleep disorder group did have a statistically significantly higher mean total KOOS score. The numbers were 87.2 for the sleep disorder group and 80.4 for the non-sleep disorder group. And that was a statistically significant difference with a p-value of 0.005. So a pretty highly statistically significant relationship that the sleep disorder group had pretty clearly better KOOS scores. So a really interesting finding that that group did not do worse. If anything, they started worse and they got better in the end.
Now, as a follow-up point to those numbers, Fehmi, what's your take on just that? The sleep disorder group starts out preoperatively with lower scores, which, as we talked about, it's generally found that those with sleep disorders have higher sensitivity to pain. And if they're both in pain because of osteoarthritis, I would think that the sleep disorders would be lower, which they in fact were before surgery. But then after surgery, as Dr. Benner just mentioned, you look at 1 year and it's highly statistically significantly different, favoring the sleep disorder group. So what's your take, or what's your thoughts on why that sleep disorder group seemed to have a better progression through time?
Yeah, it was definitely really interesting to see those results compared to our hypothesis. So I think that the relationship between pain sensitivity and sleep disorders is, as this study kind of showed, not completely understood. And it's possible that pain may modulate sleep problems more than, vice versa, even though, as I mentioned in the introduction earlier, literature points to the fact that sleep problems affect pain more. So patients that have sleep problems, like our results show, they may be doing worse preoperatively, and that may be due to pain sensitivity. But then once, they undergo surgery, then they may be more receptive to greater improvements in pain as well, because they're getting better sleep. So like I said, it's a bidirectional relationship. So maybe if it's improving their sleep a little bit after they recover, then their pain gets better in turn as well.
Yeah, it's a little bit difficult to wrap your head around this data once it gets done. In the same way that we talked about or in the pre-study phase, I guess, when we're trying to conceptualize what we thought the hypothesis would be, we really thought that it would do worse. But you could also have made an argument that the hypothesis would be that they would do better, because if they're hurting more, they're not sleeping as well, and if their pain goes away with surgery, maybe their results get better because they are able to sleep better in addition to having pain relief. And then in the post results phase, after we get into the discussion about how we wrap our heads around this data, I think those things really seem to play themselves out, that the patients who had sleep disorders had worse knee function preoperatively from something that seemingly wouldn't directly affect their knee function. They're not talking in these COOS questions about how well they're sleeping, except people with sleep problems did score lower on them, and vice versa. Post-surgery, we don't ask them about whether or not they're sleeping that well. On the COOS, we talk more about knee functional things, but those things all scored higher in these patients. So I think the learning point here, and you can talk about this a little bit as well, is that pre-surgery, if people have sleep disorders, that just compounds the problem, and that post-surgery, patients that had sleep disorders were so bad that post-surgery, not only did it make their knee feel better, but it improved their overall outcome, from presumably because their sleep was better since they weren't hurting anymore.
Yeah, Fehmi, your synopsis on the rationale for why sleep disordered patients seem to do better, and Dr. Bender, to your points as well, is, I come back to a lot of total knee research out there. In my opinion, especially seeing these patients post-operatively from a rehab sense, is a lot of it's perception. When you see somebody that's doing so poorly so early, or before surgery, I should say, you get them on, or you have a total knee replacement, you take that pain away. That's really a pretty substantial change for these patients, especially when you're starting off at such a poor functioning. And I don't know if the sleep disorder group kind of sways that way in terms of their perception of their problem is worse because they're catastrophizing their pain because of that sleep disorder. And one thing I found really interesting, and we'll put the poster that Fehmi did up on our social media pages so you know what I'm talking about here, but if you look at the graph that is put together, it's pretty fascinating on how quickly that takes place. You look at the preoperative sleep disorder group, starts off about 40 before surgery, and then at 1 month jumps all the way up to 65. So they're making a 25-point gain within a month, and I think that's really telling for this sleep disorder group, because you take away that pain piece because of the surgery as a pain relieving procedure, and they're still having a chronic sleep disorder obviously, but that perception of pain I think is much better, and you can see that as quickly as 1 month, and that contrasts with the non-sleep disorder groups before surgery starting at 45, and they get significantly better as well as they jump up to about 60, but you're talking about a 15-point increase for the non-sleep disorder group compared to that 25-point increase in just a 4 weeks time, which I thought was really fascinating.
Yeah, and Scott, so I remember actually when we first saw these results, one of the suggestions that you had made as far as to the rationale of why we saw the results pre-op versus post-op made a lot of sense too. We talked about sleep disorders and pain sensitivity, and you had mentioned it's possible that patients with sleep disorders may just be more sensitive to changes in either direction. So, they may be more sensitive to heightened pain, but then they may also see greater improvements once, they get their total knee arthroplasty done. And it's interesting because I read a couple papers on the exact mechanism of why there seems to be a relationship between sleep disorders and pain. And some of the literature pointed to actual elevated inflammatory markers in patients with chronic sleep disorders. So it's just interesting. Maybe, after total knee replacement, after the especially first few weeks, once the inflammation goes down, maybe the reduced inflammation is a possible mechanism of how these patients start to improve and their pain sensitivity is lowered, and they get better sleep, and then they get lowered pain, and vice versa, and improve over time.
Yeah, I think we've learned pretty convincingly from this study that that sleep disorders and knee arthritis really make both problems worse. I think, trying to figure out the chicken or the egg thing, is the pain worse because of the sleep, or is the sleep worse because of the pain? I think the answer is probably both. that patients with sleep disorders who are already having a big problem, they get a sore knee, that makes everything worse. They get their knee fixed, that makes their pain better, and it makes their sleep disorder better. And it's just a much bigger impact. So I guess as we start to use this data, there's nothing we're going to do about this. I mean, nice thing would be able to do if we could give all these patients narcolepsy, they'd feel better. Maybe that's how we should go about that. But I don't think that's going to happen. So instead, we have to say, this is more going to be about a patient counseling thing. So how do we counsel our patients, and how do we change our practice, if at all, or improve our results of surgery based on this data?
Sure. Yeah, I think, mostly orthopedic surgeons like to focus on the objective measures postoperatively, and that's been the traditional method of how is this patient doing, better or worse. And so in this case, I think it's important to also realize like mentioned earlier, psychosocial factors. So not just sleep disorders, but patients that may have anxiety, depression, or other factors like fibromyalgia or anything like that. I think you have to be aware of that, and I think it would be useful to have a talk with the patient, regardless of which one of those he or she may have, how that may affect their outcomes postoperatively. And so maybe if they understand what to expect, then it may change their perception over it as well. And specifically with patients with sleep disorders, I think, Dr. Bennett, like you said, I think regardless of whether patients have sleep disorders or not, the ultimate message is that total knee replacement can improve their outcomes, patient-reported outcomes, because it's getting rid of significant pain, and in doing so, improving their sleep. So I think that we can counsel them that total knee replacement can benefit them regardless.
Yeah, if somebody would have asked me this before we did this study, I also have this sleep disorder. I only sleep a few hours a night. I don't get consistent sleep, and my knee is much worse, has made all this worse. Have you had patients that have had this before, and am I going to be able to sleep better post-surgery? I would have said beforehand, I probably would have said, yeah, I think that makes sense. I don't know really, but sure, I guess I think that would potentially make you better. Now I think we're at least armed with some data to say, actually, we found that patients who have sleep disorders, don't sleep well, actually not only get good pain relief, but hopefully that will even maybe make your sleep problem better. And we have some data to be able to back that up that says that people what they're experiencing, that not only is my knee a problem, but I also can't sleep. This feels even worse. Is this going to get better in the long term? To be able to acknowledge that's what our data has shown us, that patients like you who have sleep disorders are worse off because of it. But the good news is that post-surgery, they do just as well and even a little bit better.
Fehmi, you've done a great job presenting this data. I think it was a great project with some pretty interesting and compelling results. However, with any study or any project like this, we do want to touch on any study limitations. So what were the limitations of this study for you?
Yeah, definitely. Like I mentioned earlier, it's a retrospective study, and regardless of the fact that it was prospectively collect the data, there's some inherent retrospective study design flaws that can affect this project. And some of the other things are, we talked about how we define chronic sleep disorders using CPT codes, and we know that electronic medical records is not always perfect in identifying patients that may or may not have a certain diagnosis. It may have been missed or whatever it may be. So it's possible that we didn't adequately identify patients with and without sleep disorders. And another problem relating to that as well is, patients that we said have sleep disorders, how long did they have that? That's not really in the chart or indicated in the electronic medical record. So that can affect our outcomes as well. And like I mentioned in the beginning, the sleep disorder cohort consisted of, I believe, 43 patients. So relative to the non-sleep disorder, that may have an influence. And I think that's the majority of our limitations.
Excellent. All great points, and I appreciate you going over those. One last question before we wrap up here, Fehmi. In terms of your final thoughts on this project, or what's your take-home message for orthopedic surgeons seeing this type of patient or a physical therapist seeing this patient after surgery? What's your take-home message for this population?
Sure. Like I said earlier, I think that it's important to be mindful of patient factors outside of just objective surgical measures. Keeping in mind patients that may be a little bit more anxious before surgery, may have other social factors going on. And specifically with our project, patients that may have sleep disorders. And I think the ultimate message from our project is that patients with sleep disorders, even, although previously identified as predisposed to having more pain sensitivity and catastrophization, can still do really well after total knee replacement. In fact, they can do better because by the looks of it, they're getting better sleep and in turn, possibly better reduction in pain. So, I think that's the ultimate message in our project.
Great stuff, and thanks for bringing this issue to us from the very beginning, Fehmi. I think that led to us learning something, and you having access to our database. So it was a nice give and take that we were able to achieve with this study and working together on it. So thanks to Wright State for lending you to us for a little while, and thank you for your work on it. I appreciate it.
Awesome. Thank you guys as well, and thanks for having me on the podcast.
Enjoyed having you. And for all those listening, and come back to hear us again next week. We'll be back with hopefully a couple other good guests we have on the docket for the future. Tune in a couple of weeks for the next couple of presenters that we have that should be good topics as well. If you want to find us again on social media, you can find us on Twitter and Instagram at the SKC Podcast. You can find us on our Facebook and YouTube pages, the Shelbourne Knee Center Podcast, or you can email us at the skcpodcast@gmail.com to get in touch with us. Also, if you would follow our podcast, you'll be able to get all of our content, make sure you don't miss anything. And if you have a positive review you'd like to leave behind so others can see what your thoughts are on the podcast, we'd love that as well. Thank you for listening, and we'll see you again coming up soon.